Hospital. Could I ask the speakers to introduce themselves from the left, please?
Dr Lucy Jessup, Director of Public Health at the National Immunisation Office.
Damien McCallion, HSE National Lead for Testing, Tracing and Vaccinations.
Colin Henry, Chief Clinical Officer, HSE.
Paul Reid, CEO.
And I'm Mark Brennock, National Director of Communications. And Susan and Bernie are our Irish Sign Language interpreters. This briefing is being broadcast on the RTE News channel and on the HSE live Twitter feed. And first, could I ask Paul Reid to give his weekly update?
Thanks, Mark, and good afternoon, everybody. Doesn't seem that long ago, but around this time next month, 2 years will have passed since we started to prepare in the HSE for COVID-19, so back in January 2020. One of the most disheartening experiences, I guess, for everybody throughout the pandemic is that on every occasion when we feel that we're nearly through the worst, the virus emerges again with another and indeed more impactful threat at all different times. And unfortunately, this seems to be where we find ourselves once again. It's unfortunate because at a time when we appear to be making good inroads into conquering the immediate impact of Delta variant, another threat emerges, and we find ourselves at a time when we would have hoped to dismantle many of our defences. We can't dismantle them, and we find ourselves having to put up even stronger defences again. All that said, we can and should take good confidence from the recent reaction from the public, which has made a very significant impact for us based on their actions. For the first time in many weeks, we're seeing a consistent and trend down in hospitalisations, which I'll come back to shortly. But ultimately, overall, we're at 443 COVID patients in hospital this morning, which is 18% down on last week, and in ICU, 105 patients mid-morning this morning, which is down 11% on last week. Of course, we do hope that we see this trend continue, particularly as we come to Christmas, and so that more COVID patients in particular can get home to see their loved ones for Christmas. But more importantly, as important, we need to see a continued downward trend because the base level that we're at puts us at extremely high risk levels. If any of the levels of predictions related to Omicron emerge as true, so it would be an extremely high level to go into a wave of Omicron. So key kind of reflections is January 2021, if we look back, was probably a time that everybody involved in healthcare wants to forget. Our GPs were almost overwhelmed with what they saw back in January 2021. And we had over 2,000 people, COVID positive patients in hospital and 212 in ICU. And they were really dark days for our healthcare workers who saw no end in sight to it. And indeed, all non-COVID, non-urgent, non-COVID care had to be ceased for a longer period of time that we do know gives us wider and longer term impacts in the health service overall. So 1 year on from January 2021, none of us want to even contemplate some of the impacts being put back upon our health system once again. So again, let's proceed with the required cautions through Christmas and New Year and sustain, at the very least, the defences that we have put up. They have made a difference in the last few weeks in particular. I just want to step away a brief moment from COVID, and I will come back to it, but just to reference in relation to the Brandon report, which we published on our site today. So this morning, actually, we published the independent review of the management of Brandon report. It's published on our site and was carried out by the National Independent Review Panel. The report does outline an appalling set of failings in care at a HSE-run residential and day service for adults with intellectual disabilities in the Northwest. Certainly since I've taken up this role in 2019, this has been one of the most repulsive reports that I've read, and indeed one of the most gruesome reports that I've had to read in my career. Every day, all over the Irish health services, thousands of people put themselves in our trust and care. And every day, all over the health services, thousands of our staff look after those people and give great service and great care, great compassion to all of those people are put in their care. But these events, as we have seen them and outlined in the report, had shocking consequences for many people. The facts are very clear. Vulnerable people were sexually abused whilst in our care. None of us can imagine the impact this has had on the abused and indeed on their families. So on behalf of the HSE, I do want to apologise, sincerely apologise for those residents and their families. I just can't imagine, and we can't imagine, the hurt they have had and the pain in receiving the details of this report. We are really, truly sorry. The residents of the service and their families remain our priority. All those affected are and have been in receipt of a range of supports, multidisciplinary supports. These supports continue to be provided locally and oversight by senior HSE management at a national level. As CEO working with the board of the HSE, I now want to ensure that all of the findings in this report are fully embraced and implemented. We also want to ensure that no processes are compromised equally to ensure that if disciplinary action is required, it can be progressed. We've put in place a range of governance structures to provide oversight and enhanced some of the supports in this area. However, we still have concerns related to the delivery of disability services in this area. And as such, we need a stronger levels of assurances. So therefore, we will be initiating a national review into those services in this area. We'll be working through the details of this with the HSE board. We do need overall to move to a much more rights-based approach for disability services. There are many and very significant reforms being implemented in the disability care here in the HSE and here in Ireland. Today is not the day for me to list those, but there are very significant reforms that have been put in place and continue to be put in place by our great staff overall. But I would say to anyone working in this area, or indeed any families, please do speak up if you have concerns. There are many processes and procedures for families and indeed for staff and indeed for residents to speak up. And there are supports there to help you do this. So I want to move, if I can now, just back to COVID and particularly on the vaccination programme. Overall, just to make a few points up front, now over 8.8 million vaccines administered here in Ireland up to yesterday. And we now administered almost 1.35 million booster and third doses of the current phase. And yesterday was our highest day ever of this phase, with 50,000 vaccines administered. We have finalised, and you'll have seen the Minister communicate many details of it, a revised plan. And just before I just go through some level of detail in the plan, just throughout the vaccination programme, we've adapted to all scenarios that have been set out in terms of prioritisation, our clinical priorities set by NIAC in a very responsive way. We've had 17 major releases of an ICT system, and having worked with technology for a lot of my career, very few organisations implement 17 very significant changes to an ICT system without any downtime to the service itself. So I want to pay great tribute to our teams in IT who have done that. And once again, we're launching a revised plan which has many changes to it, and a revised plan which sets out to mitigate to the greatest extent we can many of the projected impacts of Omicron. Just to restate our commitment that we have said many times over the past week or so, to have 1.5 million booster and third doses completed by Christmas, and we're well on track to deliver that. Second commitment, which has been that all people in the approved cohorts greater than 50 years of age, pregnant women, medically vulnerable, immunocompromised, will have been given either A, a booster vaccination completed or their additional dose, or B, have been offered an appointment in December, or C, have had access to a vaccination through walk-in clinics, whether that's through pharmacies or ourselves at walk-in vaccination centres. Just to give you a quick flavour overall, and to make the point again that, as you can see on the slide, and we've said this over the last few weeks, we are fourth in the EU overall in terms of the per 100,000 population that have received the booster. And you'll see some very significant countries which we are still ahead of in the programme, and equally the countries who have, if you see the likes of Austria and others, the dates that they commenced their vaccination programme very well, much earlier than we commenced our programme. So we are benchmarking quite well across Europe in it. Just to give a few points on the overall plan, and again, much of this has been communicated overall over the last few days. But the revised plan is geared towards increased capacity and throughput, supporting us accelerating all age groups forward than originally planned, and equally putting in additional options for the public through various different channels to receive their vaccination. Quick summary of it from a capacity point of view, what we're putting in place are extended hours of the centres. All centres all across the country will now move to 12-hour days, 8 a.m. to 8 p.m, 7 days a week. And they will have a combination of appointments and walk-in clinics. We've redeployed very significant staffs across the health service and indeed continued our recruitment overall. We've had further supports from the Defence Forces, and I want to thank them for that, both in terms of vaccination, but also in terms of testing and tracing. We've had a request go out across all of the other government departments and public service agencies for some further support and admin support. This is a wider national effort and requires further national support just beyond the HSE. We are increasing the capacity of our existing sites with some extra bays and extra vaccinators going in. And we're also putting in some extra sites, which you'll see listed, both in Richmond Barracks, at the RDS, and indeed in Cork City itself. You'll have seen communicated the really good efforts and support already contributed throughout the vaccination programme by general practice and GPs overall. And once again, they have stepped up further. You'll see where we are gearing to get as much as possible of the 1,300 general practices across the country participating in the programme. And we are very encouraged already in terms of that. And equally on the pharmacy side, we have had up to about 500 recently up to this week, and we do expect it to immediately go up to 700 pharmacies and delivering vaccines by the end of this week, increasing to 1,000 in January. We do appreciate, particularly in the context of GPs, their prioritisation of this in terms of other maybe non-urgent services that they would normally be doing. Just on the programme overall, and Dr Lucy Jessup will give some further details on the 5 to 11-year-olds programme, but just some of the changes that are in this plan. Commencing with, you'll be familiar, the National Immunisation Advisory Committee set out 3 high-risk priority groups of the children aged 5 to 11. And we will be starting with the higher risk as it was listed, children through Children's Health Ireland and paediatric hospital centres across the country, starting next week. We are also opening the portal on the 28th of December, initially for the other 2 high-risk groups identified of children of 5 to 11. And then we will commence that high-risk group on the other 2 high-risk groups on the 3rd of January in vaccination centres and with dedicated clinics. And then finally, the remaining 5 to 11-year-olds weeks will commence in the week commencing the 10th of January. Pregnant women can get their boosters from this weekend through all channels, and people in the age group 40 to 49 have been brought forward by 3 weeks to week commencing the 27th of December for vaccination across all 3 channels. And then all other age groups will obviously be accelerated forward than originally planned, and we'll be publishing further details related to indicative dates of each age group after the 40 years and over next week. Just wanted to briefly summarise in very simple terms the options for people coming forward in the general population for the vaccine. We're obviously working through the priority groups as identified by NIAC, and that's because they are the most vulnerable groups, starting with what we've just said, the 2.2 million population of the 50 years and over and the other vulnerable groups. However, we are moving now down through the ages and population. So for the general population, if you've completed your second dose 3 months previous to the current date and have commenced the vaccination of your age group or cohort, the following are simply the options. Firstly, you will receive an appointment for either a vaccination centre or from your GP. You should avail of the first appointment offered. We will contact you and your GP will contact you with an offer of appointment. You should not and don't need to contact your GP and you don't need to contact us. We will contact you. Our GP may contact you. And again, to restate, avail of the first appointment offered. Secondly, in the interest of vaccinating people as quickly as possible, we encourage you then equally to either go to one of our vaccination centres that are facilitating walk-in clinics. Walk-in clinics continue throughout the week. I know there may be a perception they're there for Saturday or Sunday. Look at hse.ie and you will see the walk-in availability times for centres. Or alternatively, you can contact your local pharmacy that's participating in the programme who will arrange an appointment for you. So in very simple terms, that's the options for the general population as we work through the ages. I want to finally finish on, there are other aspects of our Omicron response, which is specifically in relation to testing and tracing. And you'll have seen over the phase of COVID, we increased our PCR capacity from 100,000 last year to getting close to 200,000 by the end of the year. And as of now, we will be increasing it by the end of this year to 250,000 of PCR capacity. And that will be in place by the end of this year. But along with that, we are obviously providing capacity for about 100,000 per week of antigen testing as well. So very significantly, about 350,000 overall as we head into January. This provides us with very significant reach in terms of the overall testing programme that we will be. We've also, as we've set out to you before, opened 6 additional centres and put in place a range of pop-up centres. And a contact management programme, indeed, has introduced enhanced surveillance in cases referred for the Omicron variant. Our contact management programme has also increased capacity through automation processes we would have outlined before and indeed over the last few months to be prepared for the threat of the new variant. And HSE and Department of Health will continue to monitor the impacts, obviously, of Omicron. And indeed, I want to again thank the Defence Forces who are providing support to us in this area too. So happy to answer questions later. I'll pass you across to Dr. Colm Henry.
I just want to bring you through the current disease trajectory and some points on the Omicron variant and how it's impacting in Europe and perhaps your own country. So there are 14 instances, and these figures are from our as-is, is predominantly related to the Delta variant. And so they represent a steadying of figures, not a particular, some degree of fall in terms of harm, but it relates to what we're dealing with now, which is the Delta variant. Is important to emphasise that. So the 14th instance, studying the 5-day moving average, down a bit from last week. The total numbers in hospitals, 443, down 100 from last week, with 300 admissions in the past week, and the total number in ICU, again, easing a bit, but bearing in mind that over 1/3 of all ICU beds remain occupied by patients who are there in ICU ill with COVID-19. And again, these trends, the top graph shows cases in the past week is steadying with a slight fall. Middle graph, the blue, shows the hospitalizations falling a little bit, and the bottom graph, the ICU steadying. And there always has been this lag between cases, hospitalization, and ICU. So looking at the age groups, again, dealing with the as-is, and it's important to emphasize that again and again, because, of course, we're dealing with a new threat from that emanated. It was first chanced upon in South Africa and now spreading quite considerably throughout the world. And here we see from the as-is that in that over 65 age group, they were accounting for over 11% of cases only a few weeks ago. Now it's less than 5% of cases. And this shows you the impact of the vaccine program as it kicks in with those high age groups, falling proportion of cases attributable to those over 65s. And if you look at the table at the bottom, the big drop in the numbers of cases in the 65, 74s, 75 to 84s down 27%, and so on, going right across. And we're even beginning to see a drop in cases in younger age groups too, even in the absence of perhaps attributable to the way people are responding to the measures we've encouraged them to comply with over the past couple of weeks. So what about the variant? The ECDC is looked at those 4 criteria. How much more transmissible is it? How effective are vaccines? What are the risks for reinfection and other properties of the variant? And their ECD rapid risk assessment carried out on a daily basis now, the probability of further spread is very high. The impact of the spread, very high. The risk to public health, very high. And so far, over 2,500 cases identified in the EU, EEA, and an increasing number of cases not associated with travel. Now we're seeing secondary outbreaks. We're beginning to see, as if you remember this time last year, the same story with Delta. Initially, we were tracking and trying to slow the import of a virus into a country, and then you see outbreaks begin and secondary spread within a country, which is inevitable. And they're being reported right across Europe. And on 13th December, the UK reported its first Omicron-related death, and countries outside Europe, over 7,500 cases. The WHO, their update from yesterday, they're definitely coming to a conclusive advantage that this variant has a big growth advantage over the Delta. Why is that? Well, first of all, it's a function of 2 things. One, how much more transmissible is it? And it certainly seems likely, based on all the evidence, much of it indirect, that it may well be more transmissible than the Delta variant, and it's certainly biologically plausible based on the number of mutations and where those mutations are sourced. Secondly, why is it a growth advantage is immune escape. And there's gathering evidence based on lab studies where the convalescent sera of people who've been vaccinated are mixed with the Omicron and Delta. And what we see is when you do that, there's a much hindered capability in the case of Omicron for people to develop antibody response by multifold reduction, and I'll outline them shortly. So what we're seeing here is an emerging concern based on all these studies which are gathering at pace, and the evidence all pointing towards a variant that is rapidly going to displace Delta. And the UK Health Security Agency Public Health England has upped its assessment here. The growth advantage I just talked about, they now say red, very high. The transmissibility amber, but certainly pointing towards increased transmissibility. That ability to evade immunity, whether it's natural immunity or whether it's vaccine-induced immunity, certainly very high, and that appears to be gathering pace. So look at the UK here. These are the figures coming through now. The blue line shows the number of cases. So you can see where it dipped there in the summer, began to go up, related to a Delta surge, and perhaps a little bit of steadying, and now sharply rising again. And in terms of the proportion of cases now attributable to Omicron, probably tipping over 50%. Hospitalization, we're increasing linked to the Delta. Perhaps that link wasn't as strong, thankfully, as it was earlier in this year, like our own country, but no signs yet of it beginning to rise. There's much talk about a weakened link between harm and cases, but we know from the Delta, again, if you have enough cases, ultimately some of them will always translate into harm, whether it's hospitalization or ICU. Denmark, some richer data in a way. There's the cases in red sharply rising, really sharp rise in cases in Denmark. It's certainly one of the epicenters now. And we see a rise in hospitalization going a few weeks back, and the green is a rise in deaths. The number of daily patients admitted to hospital has started to see an increase, and the number of deaths has been rising steadily. But last Friday, the London School of Hygiene published a modelling paper, and really the pace of papers is hard to keep up with. But they looked modelling forward, what's the impact here, pessimistic or optimistic, based on how effective the booster may be or how more transmissible this variant will be. And a big range between January and April, anywhere between an additional 24,000 to 74,000 deaths, and hospitalisation, a big range from 175,000 admissions up to almost 500,000. And you can see why this certainly caused considerable concern in the UK and led to the introduction of measures there last week. And in addition to this, the Health Security Agency, they're looking at the impact of existing vaccines. And what the emerging trend is that the vaccine, there's certainly the impact of these vaccines, their ability to induce an immune response with Omicron is greatly hindered, especially with the AstraZeneca vaccine. It fell to considerable levels after 4 months, less so Pfizer. But to be optimistic, the booster dose, we see a significant increase in vaccine effectiveness with a perhaps 70 to 75% reduction in infection with the booster for both those who got the AstraZeneca and those who got the Pfizer, which certainly should be a source of some hope for us. So a load of studies, I'm not going to go through these, showing again this immune evasion characteristic, which was initially hinted at with mutations and now beginning to come through in the lab studies where they're seeing a big reduction in the antibody titers. That isn't to say that has to be translated yet into something clinically, and the first papers are beginning to come through now, suggesting infection and increased susceptibility to infection of Omicron, even in those who are fully vaccinated. But as I say, the hope is that the booster vaccine will restore considerable immunity from infection. And certainly we also see evidence, we hope, that prevention of serious illness remains to some degree robust. Looking at our own experience here, hospitalizations and ICUs, we see that differential between those who are vaccinated and those who are not vaccinated. That yellow line on the left-hand graph shows hospitalization rates per 100,000, in yellow being in those who are not vaccinated and blue being vaccinated. A big differential in hospitalization, in harm that's caused by the virus in those who are unvaccinated and vaccinated. On the right-hand side, ICU admissions. Again, look at the blue, look at the huge protection to date people who are fully vaccinated have from ICU admission. Big reduction, a flat blue line. It's not completely 100%. No vaccine works like this, but the yellow line shows that even with the amount of uptake of the vaccine elsewhere, people who are unvaccinated don't have protection, particularly against serious illness. And here, despite only 15% of total positive cases nationally, the unvaccinated accounted for 45% of ICU admissions. We discussed this last week, and that remains the case, that unvaccinated are disproportionately represented in those who are hospitalised and those admitted to ICU. What we have seen up until now is, and of course we hope will continue with the booster, is this link between cases and harm has been greatly weakened. And you see that blue line, blue part of the graph represents the cases, and the other orange represents ICU and hospitals too in grey, and you can see that's greatly weakened on the right-hand side. With a recent surge there's been greatly excess cases in relation to corresponding to harm. Another cause for hope, and here's the impact of the boosters. We showed in recent weeks the fall. If you look at those two dotted lines, that's when the boosters were given to 80 pluses on the left-hand side, people over 60 on the right-hand side. We showed last week how the drop in the purple line with those age over 85. Now we see the black line begin to fall 7 days after you get that booster. Important to remember, just like that initial boost campaign, you must wait a number of days before it gives you protection. But 7 days after, we see that fall in 75 to 84s, and the 65 to 74s falling too. And that should, again, when we're looking for causes of hope, this certainly should be another source of hope for us. On the booster campaign, we see extraordinary uptake again, and there's a percentage uptake over 80s, nearly approaching 90%. Same with 70s, 79s. That's translating through in that last graph to reduction in cases. And I've no doubt it'll translate through to reduction in harm too, and going right through those age groups. And Paul Reid and Damien will say too, will outline how our aim is to get to these groups before Christmas, to have vaccinated them, offer them the opportunity of a walk-in clinic or an appointment to get vaccinated before Christmas to give them protection. Residential care facilities, 99%. Again, that's translating through. I haven't shown the graph this week. In outbreaks, we still see that wall of protection holding in the most vulnerable settings. Dr. Tedros, worried about Omicron spreading at a rate we have not seen with any previous variant. We're concerned people are dismissing it as mild. Surely we've learned by now to underestimate this virus at our peril. Even if Omicron does cause less severe disease, the numbers of cases can overwhelm unprepared health systems. And Dr. Nabarro on Sky News reported this morning saying he's never been so concerned, not just for the UK, but for the world. So my message to end with is there is a lot of uncertainty regarding the potential transmissibility, immune evasion, disease severity and vaccine effectiveness against Omicron variant, but it's all pointing that this variant has a significant growth advantage, which means it will displace, overtake Delta in much the same way as the Delta overtook the Alpha this time last year. Healthcare services, it's eased a little bit, but over 1/3 of our ICU beds remain occupied by patients who are sick with COVID. And this is going into right in the middle of a winter period. In any ordinary winter, that would be an extraordinary position to have over 1/3 of people there with one particular condition. Unvaccinated people not only have no protection, but are disproportionately represented in those who get most seriously ill. The vaccinations alone and the booster campaign alone, while it affords protection, it is not enough in itself, and those public health measures are essential to retain control of case numbers, especially facing into what we feel is happening now in Denmark, in the UK and elsewhere. Waning immunity necessitates a booster campaign. The good news is that the early evidence coming through is that booster does restore your protection that appears to have been lost with the immune evasion characteristics of this virus. And finally, as I said, prevention of infection is much easier than treatment. I'll just pass you over now to Damien McCallion.
Oh, yeah. It's great. Thanks, Mary. It's a quick preview. Okay, so just maybe on testing and tracing. Thanks, Mary. On testing and tracing, just some of the key messages, I suppose, in terms of activity, and Colin has referred to the potential risks around the new variant. So in the past week, we're still seeing very high numbers of laboratory tests, over 200,000, and close to 180,000 swabs taken in the community. So bearing in mind we have acute community and serial testing. So that's a slight increase in comparison to the same time period last week. Paul referred to our testing capacity, which has grown from 100,000 to 230,000 on PCR, and from effectively 0 to 100,000 antigen test capacity. That's in terms of test kits. So that's per person, that's 500,000 actual antigen tests per week. In terms of our testing centres now, that network has been expanded to 41 centres. We've opened up a number of additional centres in the last couple of weeks, and we have a number of others that we're exploring as well geographically to boost the capacity. And then we also have pop-ups. So for example, currently those are operating in Youghal, Carlow, Narragmore, Dundalk and Drogheda, but they move around almost on a daily basis based on where we see peaks of demand emerging. So that gives us flexibility beyond the fixed capacity that's in the testing centres. Community referrals, again, I wouldn't pay too much stock to the decrease week on week given the weather. We did lose both in vaccines and in testing. Some of our centres weren't able to operate through the storm, so that's a slight mitigation factors. The positive rate, as we know, is still high, and the contact management programme are still very busy in terms of their work. They're reflected in the number of calls. And again, we're seeing more and more people using our technology like the List Your Contacts portal, which is helping to improve the efficiency and speed at which the contact tracing model operates. You may recall a number of weeks ago, we briefed you, we'd started antigen testing for pods in schools. That's also been expanded now to the early learning and childcare sector, and that commenced this week in terms of Wednesday of this week. So just briefly on our capacity to give people a flavour again, we're close to 250,000 come January, 245,000 in December, and that'll be 250 effectively come the first week in January. And the antigen test capacity jumping up from 0 around October to 130,000 come the end of December, early January, 100,000 at the moment. So given total testing capacity of around 375,000 per week across the two main testing modalities that we use. So again, a lot of work has gone into trying to develop that capacity, I suppose, to ensure that we can respond as well as we can. And we are seeing in terms of PCR testing, for example, now in most days, there are slots become available during the day in nearly all of our testing centres at various stages. And that's certainly working a lot better. There will still be peaks and there will still be certain times, but overall we're seeing that capacity having a benefit. So our contact tracing system is still performing very well in terms of the turnaround, the median turnaround times for people end to end to get a not detected result and a detected result. I've referred earlier to the laboratories and the community swabbing and our contact tracing. So certainly we're still continuing to see increased numbers across all of the testing pathway, but the system is essentially performing well. Moving on then to vaccinations. So on our primary courses, We're seeing some really good figures. So like 12,600 people, dose 1 and dose 2 over the last 7 days. And again, great credit to our local public health teams, our vaccination teams, and a lot of the communication teams that are still working to keep trying to provide that option for people who aren't vaccinated with their primary dose. So I think that's really important. We anticipated this would have fallen off well before this. We're really happy to see those numbers week on week still continuing to see people coming forward for either their first dose or completing their second dose. Just in overall, I suppose, where we're at, Paul referred to our fourth in the EU, despite probably starting later in relation to when people receive their relative advices. You know, the figure in terms of both boosters and immunocompromised. Last week, despite the storm where we effectively wiped out the western and southern seaboards for a day and some sites for the second day, you know, over 231,000. 15th of December, again, nearly 50,000 done across all our channels. And again, you can see the walk-in clinics are delivering good numbers. We do appreciate that for some people in terms of queuing and so on, present some challenges in certain sites. And again, to reinforce, our social media through our communication team are constantly updating the waiting time so people can see in advance of travelling what it is in relation to any particular site. Or as we say in some cases, they may be able to get alternatives. But they have, our objective was to drive more people through and get more, not just capacity, but to get more people vaccinated. And in that regard, it has been very successful. Previously, we used them at the tail end of the programme and at weekends. We're now running them alongside our appointments on a 7-day basis. GPs, again, have been very invaluable in the programme, worked really well with elderly people. Colin referred to the uptake numbers, which are very strong in relation to older people. And I've no doubt part of that is the confidence they have in their general practitioner and the work that they've done to do that. Pharmacies, again, starting to increase their throughput. That started at a very low base, and thankfully now we're starting to see that number come up week on week. So just briefly, I'm not going to dwell on all of these, but to give you a flavour of where the different groups are, long-term residential care over 65 substantially completed. Those over 80s substantially completed. There will be some people there, if you remember, with a high number of people who've been COVID positive, that will account for some of those gaps. And those people can still continue to come forward when they pass the due date. 70 to 79, again, substantially completed, big numbers through. 60 to 69 now very well advanced with work over the last week. Housebound, and again, that's now gone over 1,000 people been vaccinated. And I know I've mentioned before that this is a really important service for people who can't get to a GP, to a vaccine centre or a pharmacy. And we have teams in our community health organisations that go out and actually vaccinate these people at home. And 2 people, a team of 2 over a day, would probably only do 6 people. So it's a very resource-intensive service, but a very important service for those who get it. Healthcare workers, again, substantially progressed, some to go, and we're continuing to promote that and to ensure we get more and more of our healthcare workers through before the end of the year. Medically vulnerable, again, substantial jumps in this week, now close to 200,000. And again, our aim is to have all of those vaccinated, offered an appointment, or able to avail of a walk-in, which they can at any time by the end of the year. 50 to 59s, again, just recently commenced, and again, good progress, nearly 150,000 people done out of that population size. And again, a commitment to try and make sure they have appointments, but lots of walk-ins for people, and also have the options through pharmacies. And as GPs, as Paul mentioned earlier, as GPs are working through the age cohorts, and it's really important to remember, we're still prioritising those that NIAC have identified as the priority groups and working through those. So while we're paralleling many of these to maximise it, we are still trying to make sure that we broadly try and focus on those areas that NIAC have identified on a priority basis. 40 to 49s, again, Paul mentioned it will start on the 27th of December, population size of nearly 500,000 through all channels. And Paul has described what that means for people in terms of an appointment through a vaccination centre or a GP, again, encouraging people to take the first option. And then the alternatives that are there through a walk-in, which again are on hse.ie, set out for specific cohorts, very clear information there, and also then through a pharmacy, all of whom are working through these on a priority basis. Finally then, on children aged 5 to 11, I'm just going to touch on some of the numbers and dates, and my colleague Dr Lucy Jessup will talk through some of the broader considerations in relation to children. So the population is estimated at over 480,000. That will commence next week through our hospitals, through the paediatric units and paediatric hospitals. The portal then for registration for the balance of those children that are in the high-risk category will open on the 28th of December. and Lucy will talk you through the NIAC advice, the sort of subcategories that exist within those very high-risk groups. And finally, then we'll commence vaccination of the remainder of those children on the 3rd of January with dedicated clinics in our vaccination centres. Then we will open up for all the other children from the week commencing the 10th of January. So finally, and I'm not going to dwell on this, is really the focus has been in the last week, and some of this is work that's been on go for some time. So I just want to acknowledge those people working out there in the vaccination centres and in primary care, the people who are organising these clinics that people are able to get to. Vaccination centres working 8 to 8 for all our major centres. We have some smaller satellites that we also stand up as well, and they're there to support populations perhaps where we think it can assist uptake. 3 new centres opening. Richmond Barracks is open today, and just acknowledge the work of St James's Hospital and our vaccination leads in that. The RDS will open on the week commencing the 27th of December, and we'll have an additional site in Cork City in early January. In terms of numbers, just to give people a feel for it, there's over 2,500 people now employed across our vaccination centres. That's not including, for example, all those involved in primary care. So if you look at your pharmacists in terms of teams, it isn't just the pharmacy and the GP, it's the practice nurse, it's the administration. There are thousands more people involved in primary care and supporting the programme. Our ambulance service, who also assist along with the community health organisations in the housebound I mentioned earlier, small teams, the teams that go out to nursing homes, the mobile teams that also vaccinate some of the pop-up clinics for primary campaigns, those disadvantaged groups, and so on. So there's a huge amount of work, including, for example, our acute hospitals now, where they're also looking to offer vaccination to inpatients and moving on with our maternity pathway, pregnancy pathway for people. So although our core 3 mechanisms for vaccination for people are our vaccination centres, GPs and pharmacies, we also have a wide range of teams that are operating outside that as well. GPs, again, really good support, I've mentioned it earlier, and pharmacies, the numbers growing this week from 550 to 700, with our aim in conjunction with the pharmacy sector to get that over 1,000 in the new year. So our overall drive is to try and increase the capacity, ensure people are clear on the options. You will get an appointment through a vaccination centre or your general practitioner who's participating. You will have an option to avail of vaccination earlier through our walk-in clinics, or indeed getting an appointment through your pharmacy. And I suppose that's what we want to get across to people and encourage people to come forward for some of the reasons that Colm has set out in terms of the risks and the benefits that are there for people. Thank you.
Thank you. Hi, I'm just going to give a few more details about the children's vaccine programme that has been mentioned and will be starting in the next few weeks. So first of all, just to remind people, the European Medicines Agency recommended that the Pfizer vaccine, the Comirnaty vaccine for children aged 5 to 11 years only on the 25th of November. And on the 7th of December, NIAC recommended its use in Ireland. The vaccine currently is already being used in America and Canada and Israel, and it's recommended in several other European countries. And more than 4 million children in America have already been vaccinated with this vaccine, as well as obviously all the pre-licensure studies. So who's it recommended for? So NIAC very strongly recommends to those aged 5 to 11 who have underlying conditions, who are living with a younger child with complex medical needs, or who are living with someone who is immunocompromised. And those chronic conditions include chronic lung diseases, liver, heart diseases, neurological diseases, cancer, sickle cell disease, obesity, children who are immunocompromised or may have intellectual disabilities, or diabetes. But the list is longer than that. That's not an exhaustive list, and parents obviously know their children best. So if parents feel their children fit into any of these categories, NIAC would strongly recommend that they consider vaccinating their children if they're the ages of 5 to 11. Then in terms of priority group 2, who will be the second group who will be offered the vaccine, NIAC have also recommended that all other children should be offered a chance to be vaccinated because of the favourable benefit-risk profile of the vaccine to protect them from severe disease and the consequences that can follow on from having COVID-19. For example, multi-system inflammatory syndrome, long COVID psychosocial impacts and developmental impacts. And this second priority group should be offered in line with those under the age of 40. So which vaccine are we using? It's the Pfizer vaccine, the Comirnaty vaccine. This is an mRNA vaccine, and just to remind people how mRNA vaccine works, It teaches your body how to make the spike protein to trigger immune response. It isn't a live vaccine, virus vaccine at all. It is kind of like a blueprint. It makes proteins in your body to look like the spike protein, and then your antibodies learn to recognize the spike protein so that when you see the real infection, your body's ready to fight that infection in the future. So similar to the adults, it's a 2-dose vaccine for most people, so they need to be given 2 doses 21 days apart, but it's a 10 microgram dose, which is lower than the adult dose. And those children who have immunocompromising conditions are recommended to receive an additional dose, which is in the same way as adults, 28 days after they've had their second dose. So some children will be recommended to have 3 doses. In terms of the risk of COVID-19 infection in children, as we know, the vast majority of children have very mild symptoms or in fact no symptoms, but sometimes the symptoms of COVID-19 can go on for weeks or months, and that's called long COVID. Although the risk of this condition is lower in children compared to adults, some children do unfortunately still suffer from long COVID. The risk of children being hospitalized because of COVID is very low, and indeed the risk of going to intensive care is extremely low. But children with certain medical conditions are at higher risk of severe illness and hospitalization if they get COVID-19. But looking at data from Ireland, in fact, 7 out of 10 of children admitted to hospital who had COVID-19 in this age group actually had no underlying health conditions at all. Very rarely, COVID-19 can cause multi-system inflammatory syndrome in children. And of course, if children are vaccinated, that reduces the chance of them catching COVID-19 disease and therefore reducing the potential risks of the disease if they were to catch it. And as we can see, there's large numbers of children, unfortunately, in this age group still being infected with COVID-19 at present. And as was quoted by Colin, obviously, if there's large numbers infected, unfortunately, even though the risks for individual children are low, with large numbers of children infected, there will be increased numbers of children being hospitalized and unfortunately going to ICU in some instances. So what are the potential side effects of the vaccine? Well, more than 1 in 10 people, children may experience feeling tired, having soreness or swelling in the arm where the vaccine was, headaches, muscle pains, joint pains, diarrhea or fever. And indeed, most of these can be managed quite simply with paracetamol at home. More than 1 in 100 people might get nausea, vomiting, or redness where the vaccine was given. And very rarely there's this risk of myocarditis or pericarditis. So that's inflammation of the heart or the lining of the heart. These risks are very rare. It tends to be higher in younger men. But in fact, what they've noticed is that it's slightly higher in those older teenagers or people in their 20s, more than those who are 12 to 15. So we don't know the risk of this in younger children, but it's hoped to be very low. In terms of what we're doing to prepare people, to prepare parents to think about whether their children should come forward for vaccination, we've launched our materials at the moment. So that's to support parents to make that informed decision, to explain the benefits and risks to parents. We've listened to parents to try and understand their concerns, motivations and questions. And we want to make it easy for them to find trusted information, to register their children and then come along to clinics. So we have our HSE website and our social media where we'll be putting lots and lots of messages. We've got a dedicated webpage and our social media campaign is now live, and we'll be extending that over the coming weeks. So the leaflet is already available. We're translating that at the moment, and it'll soon be available in a wide number of formats. And very soon we're going to have a visual guide for children and parents about coming to the vaccination centre. And of course, when children come to the vaccination centre, there'll be a choice of stickers for them to choose from when they get vaccinated. So thinking about the clinics then, how can people access these clinics? It was mentioned there will be some clinics held by the paediatric hospitals, but then the portal will be open so any parents can just register their children on the portal if they are in one of these priority groups, so that you can, as soon as the portal opens, you can register your child on the portal. If it's difficult for you to use the online system, then HSE Live is obviously still available. Parents will then consent, either online or in person, if they bring their child along to the vaccine clinic, and we'll have dedicated clinics at the mass vaccination centres for the children to come along. We'll encourage children to bring their favourite book or toy or indeed their ear defenders to make sure that they are comfortable at the clinic, and we'll have quieter times that can be booked through HSE Live if children have additional needs. And we will be putting together some information for children so that they can explain what the process is like and why they are being offered the vaccine. So just to close, I wanted to remind people of a couple of pieces of clinical information. For children who have recently had COVID, they do need to wait for 4 weeks after they've had COVID before they can have the vaccine. The period of the 15-minute wait after vaccination that was talked about recently in the media, that's for people who have had their booster vaccine. They don't necessarily need to wait for 15 minutes, but children having their primary course of vaccine will need to wait for 15 minutes afterwards to be observed to see if they have any immediate effects after the vaccine. NIAC could have advised as a precaution that children shouldn't have any other vaccines 14 days before or after they've had their COVID vaccine. And it is important to remember, as again was mentioned for the booster vaccine, also this vaccine doesn't work immediately. You need to wait for 7 days after you've had your second dose before it really takes its effect. So that was the information I wanted to cover. Thank you.
Okay, thank you very much. And now we take questions. Fergal.
Good afternoon, Fergal Barrows, RTE News. Maybe Paul Reid first on this one. If most GPs are going to be involved in the accelerated booster vaccination campaign, they're going to be deferring routine care for the duration. Are you not concerned that that might put patients at risk of late diagnosis or delayed care, or that many will just simply go to busy emergency departments?
Yeah, I'll let Dr. Henry comment in a second, but just to say we are in strong contact with the GPs, representative bodies, the IMO and the ICGP. Many of the GPs themselves have a lot of information on their specific sites explaining what they will be continuing to do. And that does include urgent care for people who need urgent care. And it does set out some more routine tasks that are not urgent, that they won't be prioritising at this point in time. And we would have worked through that, through Dr. Colm Henry with the ICGP. So there's obviously higher demands on us as we head into winter, and it's obviously a concern for us, particularly in our emergency departments, attendances and presentations. But we will be working very closely with the GPs. But our kind of risk benefit at this minute in time is protect as many people as we can, which puts up our stronger defences to the greatest extent we can for what we know will come at us in terms of Omicron. So it's that balanced risk approach.
Clearly, in terms of healthcare priorities, if you look at the waning immunity and the greatly reduced ability of the existing completed primary vaccination programs against the Omicron variant, this is a healthcare priority. And it's reflected in our work with GPs in our agreement with them this week. And that isn't to say that they're suspending unscheduled or critical care, or indeed childhood vaccination programs that are as important, but it reflects a whole healthcare system priority in the face of the evidence that's emerging of the threat that Omicron poses to vulnerable individuals, to older people, and to healthcare systems. And I quoted earlier, Fergal, David Nabarro's quote that he's never been as concerned since the beginning of the pandemic, not just for the UK to whom he was speaking, but for the whole world in terms of the potential impact of this variant through sheer force of numbers alone, albeit perhaps at a lower conversion to hospitalisation on healthcare systems.
And Dr. Henry, while I have you there, do you know at this point how many further cases, official cases of Omicron we had? We had 42 up to yesterday. Have you any update on that?
What we are seeing is, you know, that we use this S gene dropout as a marker through one particular lab. We are able to detect the percentage of community cases that have SG dropout. That's now risen to 10% of community referrals there. So in that particular lab, 27% of cases now have SG dropout. And this is an indicator of the trajectory, which was seen first in South Africa, where the sharpest of all four surges were in that most recent surge of the upstroke. And again in the UK, where we're told today that it's now a majority of detected cases.
Paul Reid, to what degree are hospitals now scaling back activity? I know they do that sometimes coming up to Christmas anyway, but over and above that, to deal with the potential pressures coming from Omicron?
Yeah, I mean, we've obviously set out, actually a few weeks ago now, the prioritisation to give in terms of protecting against COVID. So many of our elective care procedures would have been cancelled in the past few weeks. That continues to be the case. What they are doing in increasing numbers are utilising private hospitals for carrying out non-urgent, non-COVID work. So last week we used 1,700 bed days from private hospitals across the country, and very positively well over 80%, almost 85% of those bed days utilised were for elective care. So we are still seeing some elective care being attended to, not at the extent that we would want. So they have certainly over the past few weeks, we asked them to de-risk the hospitals as we come up to December, and they've done that quite well.
Just and on the Brandon report, the Brandon facility, which you referenced there earlier towards the start, can you tell me how are the people who were abused doing now, and what measures are in place to help them post-abuse?
Yeah, obviously on the concluding of the information about this, we obviously made immediate contact with the families concerned and the residents, and they are getting a range of multidisciplinary supports to support them through all of this. This has been quite gruesome in terms of the report itself, and indeed there's no doubt the sexual abuse suffered by the residents and the impacts that has had on their families. And I, on behalf of the HSA, are truly sorry. This is one of the most gruesome reports I've ever read or has ever been brought to my desk. And I can assure myself, the HSA executive, and indeed the board of the HSA will be following through all levels of the recommendations and continuing to seek further assurances in relation to this. We have put in place a range of recommendations that have come from the report around oversight, which is an independent steering group overseeing the implementation of the recommendations, reporting to a steering group headed up by the Chief Operations Officer, and indeed then reporting to myself on a monthly basis on progress. But this is quite a shocking report, and my heart truly goes out to the residents who were abused by another resident and indeed their families.
Finally, for me, can I ask you about the cyber attack on the Coombe? I know the Coombe is a voluntary hospital, but it has been cut off, I suppose, now technically because of the attack from the main national health infrastructure. But any indication, as we speak now, that any other hospital, HSE or voluntary, has been affected?
So just in quick summary terms, Fergal, it was recognised last night, as was happening by the Coombe themselves, as a moderate risk. They took a range of actions in relation to that. And certainly from our own perspective, it was disconnected from the wider health network across to avoid any further contamination and containment. Our information at this point in time still is, just before lunch, is that it has been contained to the Coombe. We don't have evidence at this point in time of further contamination across the wider health network. We did disconnect it, as I said, from that network. The services are continuing. Many of their systems are continuing. What isn't continuing is their connection to some of the national systems. And they have now this full supports of our international partner who's been working with us since our own cyber attack. And they are on site with them, supporting them, and we're in close liaison.
Stephen Murphy from News Talk. Paul, can I ask you about the Brandon report first of all? Are the management who were in place at the facility at the time of Brandon's care, are any of those managers still in place at that facility or at any HSE disability service at the moment?
Well, obviously, just in terms of Brandon, Stephen, this goes back over a long period of time, all the way back to 2003 to 2016 was the initial scope, and indeed some indications of abuse even prior to that. So it's a long period of time, and there's no doubt over that passage of time, many of the people who would have been involved in various roles, some would have retired, some would have moved on, and that's a natural process that happens. So separately to all of that, we have put in place a range of oversights, working very closely, working at a national level to provide national assurance of the services in the area. We have put in place new supports and dedicated disability managers. We've put in place safeguarding procedures to protect residents in relation to such events. So we've taken on board a range of actions and a range of initiatives on the wider disability front as well, which I won't go through now. But ultimately, in the passage of time, there's no doubt many staff have moved on, etc. And we're currently assessing a scoping exercise to understand if there are any potential disciplinary issues that need to be progressed, and that's a scoping exercise that's continuing.
Okay, so some of those managers who didn't act on the concerns raised by staff, it's possible that some of those managers might be in place still at HSE Disability Services.
Yeah, I can't go through all the detail of all of the managers. It's a long period of time. You're really talking about over 20 years So certainly many will have progressed on, many will have retired, I've no doubt, and some may be working in other parts of the services.
Okay, and then just on COVID, Taoiseach has said that they're hoping that 2 million boosters will be administered by the end of the year. I think we're at about 1.25 at the moment. Do you think that's a realistic target?
The one thing we've always avoided in here for nearly 2 years now is staying away from the numbers and targets. Sometimes we leave that to other people, but what we have committed to in simple terms was to make sure the 2.2 million people who were the most vulnerable groups identified, that they have all had either their vaccination completed by the end of December, have had an appointment given in December, or have had the opportunity to come into a vaccination centre. We don't have complete control over attendance levels, but we have committed that those 2.2 million by the end of the year, and indeed 1.5 million by Christmas time, which we're well in progress to achieve.
Can I ask Damien, I know you're publishing it next week, offering the under 40s a booster. Can you say at this point, even roughly, when you hope to offer every adult a booster? Will it be kind of mid-January, late January? Do you have a rough estimate?
Well, we'll come back with that next week. I mean, I think just what we had to do is assimilate the rollout of the plan for the paediatric as well alongside that, and we're working both of those through together. And obviously on the capacity side, we've put in a big jump. So we'll work that through over the coming days, and we'll have that next week. Like, clearly, they will come forward from when we had originally thought. Notwithstanding the paediatric has come in since that plan was put in place. So we're putting all that together, and we'll have that next week. We're not going to sort of commit, but basically, yeah, we'll be looking to take ages forward. The over 40s to 49s have obviously been brought forward from mid-January back into the week after Christmas in terms of opening up. And we expect to see similar sort of ranges, but effectively the exact dates, we'll communicate those next week.
Just can I ask Colm, obviously NEFIT met this morning. I know you're not going to tell us what's been recommended, but the projections that, the situation in hospitals could be as bad as the peak of the Delta wave. Can you maybe just explain the level of concern about the potential impact on hospitals if Omicron does take off?
Well, as you say, I can't discuss what the advice from NEFIT goes to government, and the government make a decision based on a broader consideration. But reflecting on it's a number of weeks back before any of us had ever heard of Omicron, we have been concerned over the impact of the Delta wave on hospitals and the whole healthcare system. We've described it as overheated in terms of some of the particular pinch points, intensive care beds. It remains the case that over a third of patients in intensive care beds today are there ill with COVID-19. Hospitalizations have fallen a little, but still quite substantial. We're still seeing 40 to 60 admissions per day come in with COVID-19, and that's, as I said, predominantly with Delta. And GPs have been certainly feeling overwhelmed for a number of weeks now, and you've heard about the testing and tracing system. So the as is, while it's eased a little, it remains a very overheated healthcare system. All we know about the Omicron is what we're seeing from abroad, and the pointers to that is something that has a distinct growth advantage over the Delta in terms of its potentially increased transmissibility and in terms of its ability for immune evasion from either natural infection or vaccine-induced infection. And it doesn't take me to tell you or anybody listening today that we're worried about this because the WHO are very worried, and the ECDC are too, and some significant spokespeople who've been a calming influence over the past year have said they've never been as concerned.
We probably didn't touch on it in our own presentations, but our thoughts are very strongly for our healthcare staff at this point in time. Everybody remembers when we were heading into this period last year, the concern they all had, what they were coming back to, and what they came back to was horrendous. And we had many staff here talking about their experiences of it. And so just want to say today, we are really thinking of our staff. We're doing the analysis, people are doing the assessments. They are thinking about what it's going to be like. So I just want to recognise we're certainly with them.
This one for Colm as well as for Paul, just to follow up on Stephen's point about Omicron. Obviously, the NHS in England said that they were anticipating, as Stephen said, things to be as bad, if not worse, than last winter. Could I just ask about what sort of measures are being put in place then in hospitals to prepare for that, when we would expect then, in light of what we know so far about Omicron, the worst effects in hospitals? When around, in terms of week or month, would we see those?
We
We already have substantial infection prevention control measures. We've seen with the even with the Delta surge, we've seen a much lower conversion in terms of outbreaks in healthcare settings, and we've seen a much lower number of people of hospital-acquired COVID. That's still in double figures. When way back in January, Richard, you recall, we were seeing over 500 a week. We're seeing much lower numbers of healthcare workers in acute setting acquire COVID in the healthcare setting. And these are all measures of a much more robust and resilient system, albeit with a staff now that are exhausted after almost 2 years in a battle against COVID and now facing into potentially another threat. The answer is, and it is the answer I'm going to give you is that the easiest way for us to deal with this is the powers with us now to try and prevent what could be a huge surge of cases. And the early signs, certainly from South Africa, they're seeing an early surge in hospitalisation. There is some indication that the conversion rate, that is to say the number of cases as they translate into hospitalisation, is a lower rate than we've seen for Delta. But either way, we know from the Delta experience that if enough people get infected, then eventually that will translate, even if it's a lower conversion, to a healthcare system that's overwhelmed no matter where you live, no matter what country you're in. So our strategy has to be, first and foremost, that first line of defence, which is the way each and every one of us in society responds to this, and how we all try and prevent being an agent of transmission, how we all not just get vaccinated, but get the booster, and how we all comply with the advice that's been given out. That is hard to hear and hard to persist with, but it does work. What do the hospitals do? What the GPs do? Our healthcare priority, obviously, is in getting those boosters out now to afford extra protection to those vulnerable groups.
Just that, in terms of second and third lines of defence, in working with the hospitals, what we are doing is, obviously as part of our winter plan, we're looking at further capacity, both in terms of acute beds and step-down beds. Separately, we're also working with the intensive care units, intensivist consultants, looking at, and we have been looking at it, what scale up could we get to? We know we got to 350 ICU beds, and there's a level of risk beyond that, and we're looking at scaling beyond that number again. So we're looking at that, and then the range of actions that we put in place in the previous few weeks to turn the dial down on non-urgent care, and then finally the usage of the private hospitals. We've been talking with the private hospital groups as well in terms of the availability of utilisation and utilisation of their capacity as well.
Modelling in terms of when around time-wise are we expecting this to really impact on the hospitals? Is there any sort of estimate on that?
There's certainly modelling from the UK has come through last Friday from the London School of Hygiene and Tropical Medicine, giving optimistic and pessimistic scenarios depending on the emerging evidence of this advantage this variant has over, and that points towards anywhere in the UK between 150,000 and 500,000 admissions between January and June of this coming year. Clearly, our own modelling people through Philip Nolan and here within the HSE working with them are looking at the potential impact superimposed upon an existing pressurised healthcare system and the other seasonal viruses. Last year we got a buy on flu with no lab recorded wild flu. It's unlikely. We've already had 1 or 2 cases this year. It's unlikely we're going to enter another flu-free season. So there are substantial challenges ahead.
Paul, just from the HSE's perspective, it's different in other countries. I know the recommendation here is if you've had COVID within the last 6 months, you can't have your booster until 6 months have elapsed. That is different in other EU countries. Is that something the HSE would like to see and NIAC make a consideration on? Because obviously there is the concern with Omicron that reinfection does appear to be, that appears to be something which Omicron has an advantage on other variants on.
Just going to check the most recent advice from NIAC in terms of still to 6 months?
Yeah, it is still 6 months. So long as you've had a full primary course of vaccine, it is still 6 months. And that's because that your infection acts as your booster. So it gives you a natural boost to infection. So that is what the guidelines is. Obviously, NIAC changed their advice looking at evidence. So if evidence emerges that with Omicron, maybe that needs to be reduced, that I'm sure they will be looking at that. But at the moment, that all the evidence shows you actually make a really good response after you've had an infection, and therefore you don't need your booster for 6 months.
Just on terms of boosters, obviously the Pharmacy Union, Paul, have been calling for, because of the miscommunication, any of the appointments which have been made for people aged under 40 in pharmacies, they want those to be honoured. Does the HSE have any issue with pharmacies have taken bookings for boosters for people who are aged in their 30s, say, with those going ahead?
I think if you take it at the top level, what we want to do is, and nobody's saying this, give us consistency, give us clarity. We're working down through the age groups, and that's the way we're doing on the vaccination centres. That's the way the GPs are doing it in their clinics, and they will work down to the aides and GPs. And we're saying the exact same to pharmacies. I'm sure they've honoured some appointments that they have had for today, but what we do want to do is work through that level of consistency down through the ages. And that is the reason being we're addressing the most vulnerable who are at risk, and to go any other way, from much younger ages before we get through the most vulnerable groups. It's medical evidence produced by NIAC, and that's why we're doing it this way.
I'm Niamh Griffin from the Irish Examiner. Just to go back to what you were saying there about the ICU beds, there was a study you maybe saw yesterday about the impact of caring for patients with COVID between an ICU and what the study called adapted ICU beds. How many of those 350 beds are, fully equipped, fully ready ICU beds, and how many are adapting?
Good question, Niamh. We did, if you go back briefly to the to the January-February surge, working with the ICU community and relying on suspension of non-urgent care and redeployment of staff and retraining or training of some of those staff to under supervision, our model provided that we could provide intensive care for up to 350 beds and maintain the quality of care. Beyond that, of course, no care would be refused, but we felt we would not be in a position to provide the same quality of care because the resources simply weren't there between trained staff or staff that had been trained up or redeployed staff or whatever else resource was needed. So what we did, if you go back to last year, when we looked at outcomes, our outcome based on the first surge showed about a 20% mortality in ICU patients in the first surge in 2020. And that compared to some countries which had up to double that mortality. And the biggest single difference at that time that was seen was where care became overwhelmed existing ICU systems, and where it was delivered outside ICU systems and by staff who weren't experienced or trained or whatever, that the outcomes and the results clearly weren't as good. And that's so our model now, working with the ICU community, is to see how we can build on our existing base numbers to provide additional temporary beds and maintain quality of care as best we can. And that's what that number is based on.
So it is a mix of the temporary beds and the pre-existing.
Yes, some of the beds are additional beds identified contiguous or near ICUs. The staff involves staff redeployment. There are some staff who has skill set close but not identical to what ITU staff are, and they're the staff, whether they're theatre staff or anaesthetic staff or otherwise, who might have a skill set close to what is required, and that's what those extra beds, the resource, it leans into.
And just, Dr. Jessup, you said that the children need to wait 14 days before and after. Is that going to be quite tricky? I think that that age group are getting the younger ones are getting their MMR vaccines at the moment. Aren't the schools teams trying to catch up with all of that?
Some school teams might be finishing off this term, but then it will be into the January-February time. So we will be working with school teams to make sure that we're able to leave that gap if children have just had their COVID vaccine.
Hi, Louise Byrne from the Irish Daily Mail. Dr. Henry, in your report, you said that the cases in the over 80s are up 8.1%. Do we know where that is?
If you look at it should say mine. There are very small numbers of cases there in the over 8. So in the over 65s, they constitute now 4.6% of total cases. So there are very small absolute numbers in that age group. Yes, they've gone up a little bit, but it's a very small baseline. But the overall over 65 age group is going down week upon week as a proportion of cases.
8.1% looks quite big, but is that
It's
just because it
number,
started?
yes.
Yeah, okay, that's fine. Is there any news on the J&J jab for the younger cohorts? The Taoiseach said in the Dáil earlier that he understood the updated advice has been received from NIAC on it.
There has. I'll ask Lucy to comment on the.
So the NIAC advice that we have at the moment is that they should be vaccinated with the 30 to 39-year-olds. So once we go down to that age group, that's when they will be offered their booster dose. There is no updated advice that I'm aware of that is any different to that advice.
And that was a recognition of the waning immunity in the context of the Delta variant that we knew about.
It was exactly, yes, but also, as has already been mentioned, that the older groups are much more at risk of severe COVID than those people who are in their sort of 20s in the main.
Just to come back, the COOM on the cyber attack, do we know what the impact, or if any impact, that's having on patients, and how long there could be any disruption for with that?
Yeah, Louise, most of the services are continuing unimpeded. There's a couple of, when we disconnect them from the national network, there's a couple of key systems. So radiology, they connect to the national network for the radiology. So that'll be impacted to an extent. And some levels of patient management systems that they would rely on national level. But primarily, most of our services are operating okay. Obviously anxious to get them back to the national network, but we'll do it in a very cautionary way.
And just finally then, on the Brandon report, there's been some calls today, mostly from the opposition parties, for the full report to be published. The Taoiseach again said in the Dáil that advice is being sought from the Attorney General whether that can be published, or whether it can be published in a redacted form perhaps. Is there a reluctance there for that to be published, and if there is, why?
There's a few key points to response, Louise. Obviously, we're very keen, and our board are very keen to demonstrate openness and transparency. And we're balancing that with a few key issues. First of all, the process itself was a national independent review panel process, and that process has worked to give people assurance, and so people will come forward and give information, and their confidentiality will be protected. And that's a process we want to protect for the future, because it's a very important process, how we got this information from, so we have to protect that. Secondly, it's a very strong view and recommendation of the chair of that national independent review panel that that's the way they went into the process, and that's what should be protected to a level of confidentiality. And thirdly, we want to protect any other processes that we are running. We don't compromise any other processes. So, for example, a scoping review to assess should disciplinary action be required. We don't compromise any of that. So the process is really important for us. We want to protect it for the future equally. The details in the report, I can assure everybody, the findings, the recommendations, all of them are committed. And it is indeed quite a gruesome read as it is. So it wasn't to extract information, it was to protect certain processes we want to protect.
Help you overcome some of those issues though?
We're taking our own advice on it in terms of what's the best way to do that. And ultimately, what we have there is exactly what gives everybody the details of the report. To the greatest extent, we want to give the greatest, all the levels of details in it, which are in the report. What is protected is to protect us for other process, and really importantly, the National Independent Review process itself, and the chair of the National Independent Review Panel recommendation themselves.
Hi, Simon Carswell, The Irish Times. Paul, just on the cyber attack on the COOM, the PwC report last week described the HSE's IT system as frail. Does this attack overnight show that the systems of the health service are vulnerable to attacks or exposed or sitting ducks, given the frailties in the system?
Two parts to the response, Simon. Obviously, this came through a single voluntary hospital. So the attack was on a dedicated voluntary hospital, which does have connections to our network. Specifically related to PwC report, we do have a legacy network. We do have a frail network. And our network, as indeed other government networks and other departments, are vulnerable to cyber attack based on their potential to access into networks. So there's always a level of vulnerability. We do believe the actions we took when we did have our own cyber attack have mitigated some of those risks, but there is always a level of vulnerability. So we now have 24/7 monitoring of our network, a team who are actually in place in the COOM today on the ground. We do have changed a lot of the security access protocols. We have also changed and put in place multi-authentication process, so people, as they're logging into certain systems, have to authenticate themselves and we can prove it's them. And we have put in significant training and education for people around phishing emails and attachments. So we try to mitigate it, but we do know networks are vulnerable, and we do have a frail and non-integrated network that has exposures.
Just in relation, to follow up to Richard's question there about the pharmacy union wanting the HC to honour booster booking. So, do you want those pharmacies now that have booked booster appointments for people under 40 to move them out and clear them out and delay them until they become eligible, or how do you want that fixed?
I might just ask Damien, he might be in a touch with him.
So our focus, I suppose, just to be clear, across all the channels between now and Christmas is those groups that are identified as the highest risk between now and Christmas. That's people over 50, medically vulnerable healthcare workers. There's substantial numbers there to be tackled, and all sectors, not just pharmacy, our GPs and our vaccination centres. That's the focus between now and the new year. We'll look at that again in the new year. Obviously, the issue that occurred in terms of the communication shouldn't have happened, but that was a very small window. So our focus now is to try and ensure that we offer those opportunities to people over the next week to 10 days, certainly up until that 31st of December, so that we get the maximum number of people vaccinated, and also we adhere to the NIAC guidance. So that's our focus, and it's not just the guidance. We know those are the riskiest groups. Colin and Lucy have referred to it, and that's where we want to put all the channel and all the energy in over the next few weeks, and then we'll take stock from there in terms of how we move from there. And as I said earlier, we'll publish the plan next week in relation to the other age groups, the younger age groups, in relation to getting them vaccinated also.
Of the pharmacies is to come on board, and it's a real play. I mean, we know December is a busy time for them from a retail perspective, but this is a national priority, and we're really urging them all. And we're saying we 500, we expect of 700. I'd really like us to see have 1,000 pharmacies on board, and all the IPO are working with us strongly in that regard. But that's a real call from us. This is a national emergency.
It's slightly broader, but in terms of the vaccination centre and the walk-ins, we know there's been challenges around queues, and that's unfortunate and difficult for people. No one wants to queue in terms of weather and so on coming into this period. But what we'd encourage people, if you check the social media for HSE, the Twitter account, it gives you up to date all the time where the centres have lots of access. So people can opportunistically nip up, get their vaccine. And many of the centres today, for example, don't have queues, don't have excessive queues. In some ways, that's the challenge we face between actually trying to have sufficient numbers coming through those walk-ins, and we're balancing that with appointments. So look, what we would say is encourage people, as we've said earlier, you will get an appointment through your vaccination centre or your GP, and GPs now are really going to be ramping up over the next number of weeks. There's a really strong commitment there from general practice, and we're seeing that in the numbers, even in terms of supply and so on, the orders that are coming in. And then the alternative for you is that you can go to a walk-in clinic, and they're regular. There's 15 to 20 nearly every day. And then also then you can go to your pharmacy where they'll give you an appointment as well. So I suppose we're really trying to encourage people in this window through to the end of the year for those risk groups to try and get to those. And that's our focus and priority, really.
Damien, could I ask you just as well, just the pipeline of stock that's coming in on vaccines? Could you give us some idea as to how much we're getting in on each vaccine and how it's matching up with the supply that's required for the booster program, if you could?
So in the first instance, we'd obviously preserved and built up a stock to support us in relation to the booster program in terms of the numbers that are coming through. Those orders have restarted over the last week. So we still have sufficient stock in terms of our vaccine centres. As you know, at the moment, we're using Moderna, and we're managing that, I suppose, stock in relation to expiry for both Moderna and Pfizer at the moment. So at the moment, we're in a comfortable position in relation to stock, but it is an active issue that we have to monitor. Clearly, we'd like to get to a point, I suppose, where the demand is almost greater than what we'd have where we were before, but we're not at that point at the moment, clearly. And that's why I suppose we're trying to drive up the capacity, what's available, drive up people through and getting the groups through. And as I say, for this window now, for these remaining weeks to the end of the year, is really focused on those vulnerable groups who are most impacted by the sort of challenges that Colin set out in relation to the new variant earlier.
Last question for me. This may be one for someone for NEFIT or government even. France has banned British tourists amid concern over the rapid rise of Omicron. Are we in that kind of realm, Colin, where we would be seeing kind of borders going up again because of the concern of, even though Omicron is here to the level of 27% of cases, as you said earlier, do you think that travel ban is where we're looking at going, given the risks of more cases coming in or increasing further?
Well, any decision of that is clearly for government, but what I would say is we're already seeing secondary transmission. So it's not just, as was the case, by the time we become aware of this variant, and by the time we identified travel-related cases, and if you go forward weeks, Simon, and we look back again, we'll always find there were other cases that we didn't know about. So there's already secondary spread happening throughout Europe. And European countries have reacted in a variety of ways with varying degrees of stringent public health measures. And I read about that report from France. It's the first particular travel-related measure I've seen to that level, certainly. But the response of other European countries has been to lean into public health measures and to accelerate booster campaigns.
Sorry, do we have any sense? The majority of cases at the moment in the country here, is it community spread of Omicron and not travel-related at this stage?
We have to do for those cases. We have to do our contact tracing and so on. So, the first few cases we had certainly were either directly travel related or being in contact with travel related. And as time goes on, there are a number of cases that we're not sure of yet, and it's inevitable that many of those cases, and most of the cases, inevitably, as with the Delta, will become non-travel related, and we're not in contact with a travel case because of secondary spread.
Hi, Niamh again. Just Damien, I think it was you mentioned about redeploying staff for the vaccinations. Where are they coming from? Like, is it community staff again, with services likely to be limited?
So it's a combination of sources. So I suppose the Defence Forces have provided extra capacity in terms of both medical staff vis-a-vis vaccinators and also in terms of logistics and operations. And again, just to acknowledge, we already had significant input from the Defence Forces across testing, tracing and vaccines. That's been supplemented. Secondly, we're also getting support from other public and civil service bodies in relation to administrative and other such staff, and those requests are being processed at the moment. Thirdly, then we've always been recruiting and continuing to recruit vaccinators, and we've been doing things like extending hours. We have retired staff, we have students and so on as well, who can come in without impacting services. And lastly, then at local level, each area is determining what they need in relation to additional staff, say for example, some of the clinical staff. So there will be people as well redeployed from some of our clinical services, but they'll be done on a prioritised basis in relation to what's there, and that will be done at local level.
Hi, just come back on that staffing question. 2 weeks ago, I asked your press office how many whole-time equivalent vaccinators you had in the vaccine centres, and they told me 700. And when I asked again this week, it was also 700. So I know you're redeploying people, but why has that 700 number remained static for 2 weeks?
So I suppose that there'll always be a bit of inflow and outflow, but I suppose in terms of this week is where we're really seeing the increase in terms of numbers coming through. As I said, some of the areas are not vaccinators, so the Defence Forces are largely in logistics, the administrative staff in those areas. So we have our panels that we're drawing off, and the redeployment's happening this week. So that number will clearly rise. 700 whole times is probably equivalent to about 1,500 to 1,600 people, because we have a lot of part-time people as well, retirees, students and so on as part of that as well. So that number will grow up over the coming weeks as we go through. But that number, the other factor I'd say is that number was sufficient, way in excess of what we had coming in terms of demand over recent weeks. So in some ways, we had more vaccinators than we actually needed in relation to the centres for the capacity. But what we're doing now in going 8 to 8 and expanding out over 7 days for the centres, we will obviously need more people to cover that over that period. But essentially, we've had more than enough vaccinators. That hasn't been our challenge in recent weeks. It's some of the other staff that we need that we've been trying to source.
Well, have you got an updated figures for no-shows? Are we still having issues where people are getting a couple of appointments and then it's being recorded as no-shows at the vaccination centres?
So, sorry, we're going up, are you? No, I mean, in general terms, there's still a level of no-show that's there, and obviously that's going to happen in terms of what we've talked before about the time period we're in coming into Christmas. That's why we split and have much more walk-ins to try and facilitate access for people alongside an appointments-based system. But the other factor here, I suppose, is the system side of things. Is we know that's functioning, we know that's working, so that's not presenting issues at the moment. So sites are managing that locally in relation to overbooking profiles, like an airline would, I suppose, in relation to estimating maybe what they think a certain clinic at a certain time will have, and then trying to overbook accordingly to increase the numbers coming through.
Paul, it's been flagged by a couple of government ministers that there could be recommendations from NEFIT on close contacts. What sort of pressure would that put on the health system if there's, potentially thousands of healthcare workers contracting COVID and a lot of close contacts who are healthcare workers maybe having to isolate for longer?
Yeah, and that's one of the very significant concerns for us, to protect healthcare workers, and obviously urging them all to come through for the boosters, and they are in very significant numbers. That's our greatest first line of defence. But we would be looking ahead in terms of impacts of healthcare workers out. There are certain derogations that have applied. We would have worked through in the past at different stages and different waves in relation to healthcare workers overall. So we would be looking at that. But ultimately, this is about protecting not just healthcare workers, workforce in general, not just frontline healthcare workers, but the workforce in general and healthcare systems across the country. So yeah, they're obvious concerns for us.
And then just one for Damien. I know you mentioned the PCR capacity is going to be increased to 250,000. I mean, are you confident that'll be enough? I mean, we've seen in London where Omicron is dominant that they've had huge pressure keeping up with the demand for PCR testing. Is that a concern?
Well, we do plan to grow it even more in January in terms of capacity. Like, clearly there's a limit for every testing system in terms of what's sensible. And I've mentioned, jointly between our PCR and antigen at the moment, that's over 350,000, and we plan to grow PCR again in early January. We have some measures that we're taking in the background. What we're doing on that is we're working with our colleagues in the department to look at what our options are around how testing is used, how it's prioritised, and how we maximise that capacity. I think, as Colin has said, at the moment, the modelling isn't at a stage where you can say that the demand will be X, but clearly there's a point where every system will hit its peak. And what we've been doing over the last few months, I suppose, is trying, we've taken that from 100 to 250. It'll go up close to the 300. And then there's a limit, as to how far you grow that. And you've got to look at how you use that capacity across all your testing capability. So at the moment, we're working through that with the Department of Health as well in relation to some of the modelling Colin said. But we know what is essential, that there is going to be a peak for every system in terms of not just laboratories, but also in terms of staffing. We've talked before about the challenges, whether it's vaccination in our hospitals or other staff. There's a limit to how many staff we can have, and staff are key, both in the labs, but particularly in terms of the swabbing processes that are out there as well.
When you reach that peak, then, I mean, what sort of things do you look at? Is it sort of maybe only testing people with symptoms? Is that kind of one of the options you might have to consider?
There's a range of measures. I mean, that's something that we'll take guidance from. I suppose NEFIT set out those testing conditions in terms of the rules, and that's something that we're working with the department and our own public health department to look at what those choices would be and how you make sure you use that testing. So we've always prioritised, we've talked about it before, in terms of GP referrals for symptomatic cases, our acute testing and our close contacts. So we'll look at that in terms of how we utilise that best if we end up in that position. So that's something, I suppose, it's a constant thing, irrespective of what the number is. We've always been trying to look at what we would do if the demand exceeds supply to that extent.
And
see advice too that you lean into PCR insofar as you have capacity.
And ECDC have guidance with their website in relation to the decisions you make and the logic and clinical basis on which you make those decisions as well. So you prioritise what testing you have towards those that most need it.
I don't want to be a bad Santa, but can I ask Dr. Colin Henry, is it reasonable to think that we might all be here in this room at this time next year talking about similar issues around COVID-19?
Yeah, well, I don't know. That we've long before this pandemic happened, there have been warnings that our healthcare systems were vulnerable because of increased globalization, ease of travel, and aging populations, that we were vulnerable to pandemics. And this pandemic necessity determined that we had to develop vaccines at speed. Those vaccines proved to be highly effective. Unfortunately, they've waned. It's not unusual. We have an annual flu vaccination program, and people are used to that for many years, where nobody expects last year's vaccine to work again. What is alarming for us in 2 successive years is how quickly a variant can take off. But what has been given us great cause for hope is how quickly the world has responded in terms of research, development and production and marshalling of multiple agencies to move from research to production, to mass production at scale, and deliver these vaccines to where it's needed. So it may well be that we're learning to live with a virus that can mutate, but we're also learning to respond very quickly.
Next week. It's about the lens we have at the moment. Yeah.